I'm Timothy Donahue. I am a professor in the Department of Surgery and the chief of the Division of Surgical Oncology at University of California, Los Angeles. So the question relates to the significance or importance of a positive margin or a close margin following a Whipple procedure, and does the location of this margin matter? Yes, it is thought that the margin status in a Whipple procedure for resection of a pancreatic cancer is important. This is really based on a lot of retrospective surgical series of patients who have undergone surgery. For the most part, the margin status is a significant predictor of survival, even after controlling for all other patient and tumor-related characteristics. It's not thought to be as important as, say, whether or not the lymph nodes are involved, the grade of the tumor. I would say that those are the biggest determinants, the strongest determinants of survival related to the tumor and the procedure. But the margin status does carry a prognostic significance too. There's more data that's come out recently, I'd say within the last 3 or 4 years or so, that not only looks at whether or not the margin is positive or negative, but the closeness of the margin. It's felt that, a true negative margin is one where the tumor is at least 1 millimeter away from where the margin is assessed. There is good data that's come out of Mass General and published in the Annals of Surgery 3 or 4 years ago that showed that, a true negative margin, so greater than 1 millimeter away from the margin, those patients have a better prognosis than patients who have what we call a negative margin, an R0 resection, but a close R0 resection within 1 millimeter. So we look more and more now, and I'd say it's in the annotated pathology reports, the distance of the tumor to the margin is an important factor to look at. And a lot of people think that a margin within 1 millimeter is almost the same as having a microscopic positive or an R1 resection margin. The other positive margin that one can have is a gross positive margin, which we call an R2 margin. And those aren't very frequent, but clearly also have a worse prognosis than a microscopic positive margin. I oftentimes counsel patients that, the only way that a Whipple or surgical resection of a pancreatic cancer helps is if the margin can be negative. And that's what we do a lot of for the preoperative setting, or spend a lot of time, in deciding when surgery may be the best in the treatment sequence for a patient, is when we think that we have an optimal chance to achieve a margin negative resection. There are 2 different types of margins with a Whipple resection. There's what we call transection margins, and also radial margins. The main transection margins are those where the pancreatic neck is cut at surgery, where the bile duct is cut, and also where the uncinate process is cut down by where the superior mesenteric artery. The radial margins are margins that are radial, so the tumor can extend more posteriorly into the retroperitoneum located posterior to the pancreas, or can even extend up towards what we call the vascular groove, where the superior mesenteric vein and artery are located. For the most part, all the margins are important, but it's thought that the transection margins may carry a stronger prognostic significance, or a positive transection margin than a positive radial margin. And I think it's just because of the way that the specimen or the tumor is assessed by pathology. You know, they look at the radial extent of the Whipple, and oftentimes the tumor can extend up into that area, but it doesn't extend through it. Where when a transection margin is positive, the tumor does extend through where the tissue planes are actually cut. There, is some somewhat controversial data out there, but it was a really good study reported by, I think the senior author is Nipun Merchant in the Annals of Surgery, maybe 6 or 7 years ago, where they looked at the importance of that pancreatic neck margin, that transection margin. Oftentimes when we're in surgery, the pathologists will say that margin is positive, and what we do if that's the case, we then try and take more pancreas and keep doing a progressive resection until the margin becomes negative. And that still is the approach, the appropriate approach. But what this paper had shown with a large series is that in doing that, it doesn't make a difference prognostically. So in patients where the margin was called positive and the surgeon stopped at that point, had the same outcome after controlling for everything else as patients where the surgeon continued to resect more until they achieved a negative margin. So a bit of controversy there, but that being said, the appropriate thing to do for the most part is to continue to resect pancreas until a negative margin can be achieved. Obviously, this requires some intraoperative decision-making and is on a case-by-case basis, but that's kind of the general principle and the general approach. So all in all, yes, it's thought that the margin status is important. It's not as strong as a prognostic indicator as, say, the lymph node status or the grade of the tumor. Transection margins are thought to have a greater prognostic significance than the radial margins. And for the most part, on a patient-by-patient basis, the surgeon should attempt to achieve a negative margin at the pancreatic neck and continue to resect to a certain degree to try and achieve that, because it does lead to better outcomes.